Okay, so this video is for the endocrine system. I'll just say this in advance. I'm not going to start reading what every hormone does. I want you to better understand the overall system. That doesn't mean that that's the only kind of questions you'll have in the exams, but the endocrine system is a very powerful system because it deals with hormones. If you remember, I taught you that hormones and enzymes are biological substances, chemical substances with supreme powers. Um, it's amazing how they can just influence function, while enzymes perhaps contribute more in the effectiveness and speed of things happening. The endocrine system, through hormones, is in charge of control and regulation, two huge ideas in function, and can flip your body within seconds. They are very powerful substances with multiple effects. You'll see that the regulation, by the way, not supervision, regulation and control. Supervision is by the brain. The regulation, especially, and supervision of the critical processes to life are governed through this system. It is the greatest effector in the body. Um, Perhaps, maybe, this is debatable. Maybe equal with the only to the brain and the central neural system. Okay, so you can see I'm going straight to slide number 12. You can see number 4 and 5 on the list there. Hormones help with internal homeostasis maintenance, very important principle and idea, and then corrective and adaptive, emergency responsive, that obviously have a lot to do with survival. You see that a hormone has a specific message, and then you will see again and again and again that the endocrine system is tightly related, correlated, and collaborates with the central nervous system. So the messages may be integrated with the CNS. Very, very important. Then, from a functional standpoint, I want you to notice the 3 types of secretion on slide 13 in the second bullet: the autocrine secretion, the paracrine secretion, and the endocrine secretion. Uh, of course, the autocrine secretion is about a cell that is secreting hormones that affect itself. So it's regulating itself. Then you have neighboring tissues and cells that are affecting each other. That is part of the communications that we've learned about in the unit about the cell. Then you have endocrine secretion, meaning that one cell is secreting hormones that affect another cell or tissue far away. And obviously, the way to get there is through the blood. So hormonal influences can be detected mostly in the bloodstream, which is not new to you. Of course, we want to use the bloodstream um, as our way to reach our target cell or tissue, because it gives you the maximum access possible, of course, only to tissues that are supplied with blood. Then you can see that similar hormones, meaning from the same family, have a similar rate, rhythm, pattern, feedback system, uh, the use of specific receptors um, being excreted or deactivated, activated in the same place and way. So they have developed to have similar influences, and yet you have multiple hormones that can achieve the same goal outcome. And that's very important as a safety mechanism. You'll see that uh, when it comes to function and cascades, you always want to have a backup plan and not put all of your eggs in one basket. And you'll see that again and again as a major principle of the system. It becomes confusing because there's so many safety guards. I don't want you to remember the safety guards by heart, more the principle, more of what the hormones do in general than who eliminates who. Although it's always good to know. Um, of course, when we're talking about the connection between the central nervous system and hormones, since hormones have such influential abilities, we do not want them to be misused, overexpressed, or underexpressed, be hypersecreted or hyposecreted. We don't want to have too much of them or not enough. And who better than the brain to supervise their function? So the connection with the central nervous system is very important and cardinal to the correct function of the body. Let's see. Then you can see on slide 17 in the third bullet, the system's function is under supervision via feedback systems and loops. This is very important for control and regulation. Um, so we have chemical feedbacks and loops that are the main tool that lead to regulation of the processes while they are intact or balanced. Then we have the two types of feedback. The negative feedback is when the inducer is also used for its own regulation. So if we're talking, let's say, about a hormone, the increase of the hormone will become the inducer to reducing it or deactivating it, and vice versa. With a positive feedback, you just continue to accumulate or elevate the amount of a certain hormone, and that usually is used to um, unbalance the system, break homeostasis, reset homeostasis, leave homeostasis for a while and come back, such as in exercise, etc. Then we have the difference between hormones that are soluble but also less stable. So if they are water soluble, it's easier to transport them on the one hand. On the other hand, they break up or break down faster, and that is why their effect is shorter. The more complex compounds, such as lipid soluble hormones, anything with lipids takes more time to catabolize or break down, but they are also bigger, so they move slower, but they tend to stay around for for a longer amount of time. Then basically, we already talked about this, but in the idea of the cell, no receptor means no function usually. So the idea of having a receptor that is fully functional and then multiple copies of the same receptor are going to influence function and the ability of a hormone to influence or not the cell. The more important the function and the hormone, um, the more you will see representation for it on the membrane of the cell. Um, and that, of course, plays a role in the sensitivity of the cell to a certain hormone according to its function. And then we can also talking about cells losing or tissue losing its sensitivity. Um, to the hormone, which is such is the case when you develop what we call insulin resistance. So that tissue loses its sensitivity to the hormone, and that means that the hormone does not have as strong as effect, if at all, as it used to have. But of course, the receptor is the embedment of the physical connection between the hormone and the cell. Without this physical connection, there's no Wi-Fi in endocrine. So without this physical connection, you have a problem. Then we can talk about a hormone having a direct effect or an indirect effect. A direct effect means that it influences directly a certain process as the end result that we wanted. An indirect effect means that it either inhibits or allows or mediates a process that will lead to the end outcome that you need. And then it's very common for hormones to be biphasic. Biphasic mean that they have a different influence in the body according to their concentrations. By the way, this is a very known dynamic, not only with hormones, it works with vitamins, it works with ions. A lot of these substances are great at low concentrations and can be lethal at high concentrations. So when we're talking about a hormone receptor complex, we're talking about a very powerful option to induce function. Then in slide 23, you can see the difference between a first messenger and a second messenger. The first messenger is external to the cell. The second messenger is internal. And then on slide 24, you can see multiple examples of second messengers that are used in the cell. By the way, ATP is also sometimes used as a second messenger. And of course, the idea of using messengers, of course, indicates that everything is about a cascade in the body, and you've heard about that as well. I'm jumping straight to slide 27, to the third point. Very important thing to remember, very influential and relevant to what we do in our field, and that's the HPA axis. If to put it into slang, the HPA axis is the physical connection between mind and body. That is how stress, psychological stress, dreams, hallucinations, emotions, and so on affect the body physically. Then, as as another point to remember in the next slides to come, and there's many of them, I want you to remember that the pituitary gland acts as a sort of storage for the hormones needed by the hypothalamus. The gland and its sub units. Then we can talk about in slide 29, in the second bullet, how the posterior pituitary gland governs hemostasis, plasma osmolality, and the regulation of ADH. All three of them are critical to survival and function. Slide 30, you can see in the second bullet the importance of melatonin. Notice what important processes it regulates. Simply, in the heart, in the center of existence. So circadian rhythm, which is a very important process to maintain. The reproductive system, obviously connected to survival of the species, and it has a role in the regulation of aging and immunity, immunoregulation. Then you can see in the fourth point, talking about how the thyroid controls metabolic rates, uh, and the parathyroid glands control serum calcium. These are, of course, very important functions as well. In the third point, NO, nitric oxide, is a very powerful and potent vasodilator. Then, if we go to slide 31, to the last point, notice that what is hiding behind the idea that TSH also induces thyroid growth. When you go back and read a few points before, you understand that this creates a loop. Then in slide 32, in regards to the second bullet regarding PTH, you can see that I wrote that it is they are the most important regulator of plasma calcium, but I did not write that it's the only one. So it's the most important, but not the only one. Then going on to slide 33, when we're talking about there's a control balance between calcium and phosphate. Phosphate is very important for function. We usually remember that it's a part of ATP, and that's what we tend to remember, but phosphate is a very important regulator of function in the cell. Phosphorylation in general is a very important process in the cell. So we're not just talking about the control in plasma, but also in the cell as well. Then if you look at slide 34, the second point talks about, in a nutshell, neural control of metabolism. You can see that all three main metabolic pathways, or ways to, or substances that are catabolized to create ATP, are governed in such a way by the brain, which is, of course, important and a means for the brain to control energy production and metabolism of the cell. So the cells are not just doing whatever they want. Then inside 35, I think it would be great to remind you that GLUT is a shuttle into the cell. So it's a shuttle to and back from the membrane. Obviously has great effects on the function of the cell, and in regards to carb metabolism. Then if you look at the next four slides, the bottom line or lines of these four slides, and I wrote it down this way, you see a complex system of regulation with multiple points of intervention, what we call safeguards, right? The more reactions and factors that you have, the better control and regulation that you have. So please, first of all, I understand it can be confusing to try and remember what each one does, but I want you to see it more as a process than anything else. Then you can see that some hormones act as a they counteract the immune system as a safety mechanism as well. The immune system is a powerful system. It has permission to engulf and kill and catabolize cells and attack them. Exactly what we don't want, to lose the balance and the regulation of such a system. That is exactly the worst part about autoimmune diseases. So we can see that we have hormonal safeguards that under normal condition and normal balance prevent such loss of regulation. But it also explains how psychological stress can lead to greater chances of diseases, inflammation, and even cancer. Then on slide 42, you can see how in the second bullet, basically it's the idea is that cortisol is biphasic. And cortisol is known to have a positive influence on the body and tissue in lower concentration, and higher concentrations it has negative influences. I'm going all the way to slide 45. We can talk about hormones. In this case, it's catecholamines, but hormones and substances can either be activated or deactivated, and you don't have to necessarily catabolize them. When it comes to hormones, we don't want to catabolize them. We either excrete them from the body, dispose of them from the body, or keep them in a non-active condition or status. The reason is that we don't want to invest time and money, a lot of time, in producing hormones while we might need them for immediate responses. It's easier, faster, and better controlled to simply activate or deactivate them. So you'll see that they are never catabolized. That would be unusual. Maybe never is too strong of a word, but they are seldomly catabolized, if at all. Then when we go on to the pathologies that start on slide 47 onward, I think that the bottom line that comes across very significantly is that when it comes to the endocrine system, the pathologies usually originate from two simple ideas. You are either producing or secreting too much of the hormone or too little. Of course, the pathologies can also be due to what we would call the hardware, meaning dysfunctions in receptors or the inability to supply the hormone, and so on and so forth. But basically, in general, you'll divide them into hyper secretion and hypo secretion. Too much, not enough, or too little. And you can see the other mechanisms, the more hardware, more mechanical aspects of how this is caused in the third point of slide 48. So you can see any problem with the receptor, with the hormone receptor complex, just to differentiate, any problem with a failure of a feedback loop, perhaps premature degradation of the hormone, and of course, anything that is related to the hormone being deactivated. In this case, if we're talking about an pathology, that means that it's being caused for an abnormal reason or an abnormal way. Then, of course, on slide 49, I hope that this sounds familiar for you, the content of the slides, because it's exactly what we talked about when we were talking about cancer or cell proliferation. Then in the last point, the effect is internal because we're talking about post-surface receptor level, meaning the inside of the cell. Advancing to slide 53, obviously in this case we're talking about a case of hypersecretion of too much ADH. In slide 54, we can talk about, in the first bullet, about all the principles and ideas that we talked about in week 2, the cell. And then in the last point, in the unique symptom, you see the lack of peripheral edema is a unique symptom. But if you think about it, that means that this unique symptom is invisible. So you might be symptomatic but silent in this case. Silent because it's invisible. Then you can see that in DI, we're dealing with a case of not enough ADH, so hyposecretion. You see in slide 56, the second point, unique symptoms, the combination, emphasis on the word combination, of frequent drinking and frequent urination. So remember that. Then in central or neurogenic, that by definition takes you to the CNS, um, everything originates in this case from the gland itself. And this is a good place to explain that in the endocrine system, a primary condition would usually originate from the gland itself, and a secondary from outside of the gland. It's you're going to see this happen again and again. Then we have nephrogenic DI, meaning it originates from the renal system. Never a good system to mess with, right? And we can see that when we're talking about acquired NDI, we're talking about a secondary condition that might be, under certain conditions, even reversible. Then, in regards to slide 61, in principle, we're talking about pressure going up because of the inability to concentrate urine. You see that the unique symptoms include urinating 12 times more per day than usual. Notice the differences, the subtleties. It's not urinating 12 times a day, it's urinating 12 times more than a normal person per day. So I'm making up the numbers right now. Let's say a normal person goes to the bathroom 2 or 3 times. This person will be going 12 times more, multiplied by 12 times. Okay, what else? Slide 63, we're talking about hypopituitarism. We're talking in this case in an internal problem. So the problem originates from the gland itself. Notice that in this case, you lack uh, selective hormones, meaning not all of them are necessarily absent, or complete failure of the gland's function. Talking about ACTH deficiency, obviously deficiency means you have not enough of the hormone. It's idiopathic. It's life-threatening. Um, and you can see that complete depletion of ACTH can occur within 2 weeks if it's untreated and undetected. In regards to TCH deficiency, once again, you're not going to have enough of the hormone. You can see that the symptoms develop between 4 to 8 weeks. So you are asymptomatic at first. Then you can see in the unique symptoms the thickening and swelling of the skin, the myxedema, very unpleasant situation to have. Of course, other possible symptoms, as you can see in the fourth bullet of slide 69, they are very non-specific to this condition. And of course, by the way, in the unique symptoms, notice the cold intolerance, meaning that this person will suffer uh, with any decrease of temperature, usually. When we talk about FSH and LH deficiency, once again, you have not enough from it. You see that the symptoms are very sex specific, especially affects women more than men. Um, and then you have also for both sexes non-specific, non-sex specific symptoms. And you have a bit of a joke on slide 72 regarding to the stunned beard versus stoned. A bit of professor humor there. Okay, now when we talk about growth hormone deficiency, we're talking about the bottom line when you read this is how the tissues, the cells, the organs go from normal size to smaller size, uh, something that can be called dwarfism, compared to uh, another condition that we'll talk about in a minute, where you get the exact opposite, acromyalgia. Then we have primary adenoma. Basically, it's idiopathic and it's an adenoma. So we're talking about cell proliferation, and just remember all the principles from I think it's what unit 3, the cancer. Um, Notice in the second bullet that it is usually discovered only after death, meaning that it's mostly asymptomatic most of the time. Again and again, you'll see as it's presented in slide 77 the idea of how masses and tumors, fluids, induce mechanical pressure that influence the environment, and that is a prime principle in function and pathologies, and it's not new to you by any means. You can see on slide 78, one of the unique symptoms that I think is easiest to understand is the temporary blindness of the person. That doesn't happen much. The rest, um, perhaps I should have written semi unique in their cases, but temporary blindness is definitely unique. Um, what else? Then we have GH hypersecretion. From normal, the tissue goes from normal size to becoming giant, to becoming too big, and of course, uh, this is caused via or due to a complete imbalance of hormones. The problem with this situation is that you have limited space in a joint or in the environment, and this tissue is growing into it, causing a lot of pain, causing stiffness, uh, limitation of range of motion, uh, hurting, injuring neighboring tissues. So this is a huge problem, and the person himself or herself are also very big, very heavy. It causes unnatural movement. Prolactinoma. Obviously, we're talking about a tumor or an overgrown mass. This, when you talk about prolactin, this is a very potent influencer. You can see how many different processes um, it influences. And because of its characteristics as a substance, it also makes these glands and tumors the most active in the body. In this case, it's usually not for a good reason. You can see that it's inhibited by another very potent neurotransmitter, which is dopamine. Uh, if you lack dopamine or you use dopamine blocking medications for other reasons, then you might have an imbalance with prolactin. You can see that estrogen, which is obviously elevated in women for different reasons, is a strong activator of prolactin, and prolactin elevates estrogen. And you can see that it's very important for breastfeeding and enlargement of the female breasts, and let's just say processes that happen before, during, and after pregnancy. But pregnancy is the main inducer for this change. Um, Going on to slide 91, you can see that the first two bullets of the slide talk about internal influences, because we're talking about a primary disorder. Of course, there are no to minimal symptoms, meaning that it might be silent when we're talking about the subclinical thyroid disease. And then we, of course, have the secondary. In this case, it will be external. Same idea in slide 93, internal versus external influences, primary versus secondary. It's a very simple principle to understand. Slide 95, starting to talk about Graves' disease. It's idiopathic usually. It is similar in its influences to most of the autoimmune diseases. Obviously, the most visible, most clear and apparent, no pun intended, symptom is the enlargement of the eyeball. And you have a photo there as well. I'm jumping to slide 100 to talk about nodular thyroid disease. You can see the two definitions that are differentiated in the third bullet, which the main idea between those two definitions is mainly the extent or the amount of hyper-functioning nodulars. Then, very important thing to notice in slide 101, in the unique symptoms, notice that the unique symptoms in this case include what's not happening versus what we usually indicate of symptoms that we can see and what does happen. So if you don't have this, it might be a unique symptom in this case. Then we can talk about thyrotoxic crisis. Basically, we're talking about a complication of Graves' disease. That's why they're taught together. Obviously, complications mean that there is a chronic imbalance, or the disease, the condition is progressive. Hypothyroidism, we're talking about mainly an internal condition, as indicated in slide 105. Of course, we have central hypothyroidism. Obviously, if it's central, it's from the central nervous system. So it is influenced by any one of the functions of the brain, of the higher centers of the brain. Then you can see that these people have low heat production, meaning that they shiver and they feel cold most of the time, unless they have an imbalance that doesn't even cause them to shiver. Most of them should. Then the last point on slide 107, of course, we're talking about accumulating water and fibers in between fibers that have disconnected or separated. This will lead to weakness, physical weakness, the inability to stand and move and hold your posture, and to swelling, of course, because you have accumulation of water. And by that, it will also decrease the range of motion, of course. Um, then you can see the myxedema, comma, which is an emergency, a life-threatening emergency. You need to um, get as fast as possible to treatment to the hospital. Last bullet on slide 108. In this case, you might have hypothermia without shivering, which is supposed to be a behavioral and visual symptom that would cause you to be alert to the situation or cause someone else to be alert to your situation. In this case, it does not exist. And then notice that all the symptoms in this case are hypo, meaning that you have not enough of the processes. So that's very unique as well. Um, Birth or labor dependent hypothyroidism, of course, uh, it is something that happens during birth, might be in some cases associated to the period of being a fetus or after birth. Uh, Sometimes the symptoms can appear even months after birth, but we suspect the mechanism to be um, related to birth. And then you can see that we have short term symptoms and long term symptoms in slide at the end of slide 110 and at the end of slide 111. Thyroiditis on slide 112. Obviously, the TIS at the end means that we're playing with infections and inflammations. In this case, you can see that we have degeneration and progression of the disease. We have the destruction of the thyroid, which is worse than imbalance or dysfunction or dysregulation. You're literally destroying, catabolizing, breaking down the gland itself. In some cases, as you can see in the last bullet, it is reversible. The severe cases, as indicated in the second bullet, are due usually to genetic mechanisms or autoimmune disorders, which is a very bad blend and combination of the two. Then you can see that with subacute thyroiditis, the symptoms may last up to 4 months after birth. That's quite a long time. And then you can see that in postpartum thyroiditis, it can be up to 6 months post delivery or birth. I'm not going to talk about the thyroid carcinoma. Basically, it's cancer. We had a whole topic about that, but it's nice for you, I think, to have in the presentation. Okay, slide 119. First of all, we can see in the first bullet that it's defined as abnormal, elevated parathyroid hormone (PTH) secretion and hypercalcemia, meaning that PTH is elevated, you have too much of it, and you have too much of calcium. You know that calcium is very reactive. You need it to be confined or chaperone, so this is a very bad idea having calcium on the loose. Then you can see also in the last point that the feedback, the control of feedback is lost or completely absent, leading to increasing plasma calcium and PTH. Elevated plasma calcium levels can lead to death. It's one of the leading mechanisms or one of the leading processes that we see in people with cancer that accelerates the end of their life, unfortunately. As you know, in regards to the absence or loss of control of the feedback, no feedback equals no control. That equals no regulation, which equals trouble. Then we can see that the secondary condition is basically a compensation response to chronic hypocalcemia, meaning you're trying to elevate the levels of calcium. You have an overcompensation, overreaction that leads to hypercalcemia. And then you can see in the fourth point that although PTH is elevated, calcium levels are not normal. Of course, you can see in slide 122 the whole aspect of imbalance of calcium and the immediate connection to the bones, because the bones are the major clients of calcium. They are huge uh, storages of calcium in a way. The second point on slide 122, I wrote, we have complete chemical imbalance, and that, of course, leads to danger. Slide 125, we're talking about hypomagnesia, meaning we have too little of PTH. This is usually due to surgery. Of course, remember that these are all, by the way, with calcium as well, these are all ions, meaning that you're messing with ion gradients that will influence the ionic pumps, that will influence, of course, ECG as well at some point. We can see that in slide 127. Sorry, the number is hidden. We're talking about a reversible and idiopathic condition. Everything in the symptoms indicated in the third bullet of slide 127 are focused or centered around calcium. Then we have the notorious diabetes mellitus, DM. As you know, and the book does a good job of reminding us how horrible this disease is, how many conditions can be influenced by diabetes. This disease is mainly, but not only, influenced by glucose. And it is my firm belief, due to my studies in life and teachings and mentors, that glucose is one of the most horrible substances. Why do I say that? Because you see how horrible DM is. And in the heart of the horrible nature of DM is the imbalance of glucose. Glucose also is a carb, of course, that will coat and connect with proteins. One of the ways to disable, eliminate, and even kill the function of substances and organisms is by coating them with sugars. Uh, Glucose is used as one of the weapons of the immune system in various stages of the immuno response. So I think it's time to never again be surprised of about how horrible diabetes is, because it is based upon the imbalance of glucose levels and all the regulation and safeguard mechanisms regarding it. Then I just want to remind you that when we look at the metabolic pathways, the basic ones in the cell, mainly the three that we use to in order to produce ATP, Proteins are seldomly used or are used to a very low extent, because when you talk about proteins, you're talking about enzymes, you're talking about hormones, you're talking about the muscle itself. So we don't want to mess with those and catabolize them if we don't have to. Doesn't mean that it doesn't happen. It happens, but at a very low extent. And then you're left with lipids and glucose. So if you have a process that is causing an imbalance in glucose, you have zero chances that it's not going to affect lipids and proteins. So, in other words, what I'm telling you is that you have a mess. Um, the chemical combination of a protein and a sugar, as you know, all sugars are carbs, not all carbs are sugars. Glucose is a carb and a sugar. These complexes are very strong and very hard to to break down, break apart. So that's a bad combination. And when we think about uh, HEB1C, hemoglobin coated by glucose, that is one of the prime examples to how bad such an idea is. Um, and basically, if that hemoglobin is coated, it exists, but it's dysfunctional, either completely or partially, and now it's affecting your ability to transport oxygen, and now you're dealing with ischemia, and that is, as you know by now, is a bad idea. Of course, DM is a group of metabolic diseases. It's not just one disease, and we have the subgroups, which are pretty simple to explain. By the way, there's not they're usually a no kind of a no brainer. Um, let's see. So we're talking about type 1 DM. You can see that we have the autoimmune type 1 and the non autoimmune type. The type 1B is the non autoimmune subtype of type 1 DM. The autoimmune obviously is going to attack the body, it attacks cells within the body. In this case, it's the beta cells of the pancreas. Um, we see in slide 135, the whole slide indicates once again the loss of regulation, which is a horrible idea always when it comes to function in the body. I think that the type 1 DM is pretty simple to understand. Then we have type 2 diabetes, which I think is the worst part, the worst type of both, because in theory you have all the components for normal regulation and function, but it is lost. And it is lost, meaning that multiple factors that could have prevented it are not being prevented. And you just have a cascade of horrible processes, starting from insulin resistance to the breakdown of the nervous system because glucose attacks nerves, metabolic imbalance, you name it. It leads to uh, autoimmune, to immunosuppression. Sorry, immunosuppression. It leads to cardiac diseases. Um, it's just, and of course, from a metabolic standpoint, the lack of glucose in the cells definitely is going to influence the central nervous system that, as you know, operates mainly on anaerobic glycolysis. Insulin is a regulator not only of glucose. Insulin is a prime center, very influential mediator and pivot of so many important processes in the cell, including the metabolism of not only lipids but also proteins. So we usually connect type 2 DM or DM in general with glucose. I want you to understand that it messes with every metabolic pathway of the cell. I want to connect you to our first topic, to the principles, and ATP is the money of the cell. It is a vital tool for survival, and that means that diabetes taps into the holy, one of the holiest principles of existence and nature, and that is, of course, what makes it so bad. Okay, I'm going to jump over to slide 145 to Modi. We're talking about basically DM in adolescence. Um, it is sex chromosome dependent, being autosomal dominant, meaning that it's enough that one of your parents has a mutation for you to have the disease, and you don't have to. It's not that both parents have to have a mutation for you to have this condition. Um, Obviously, it's a diagnosis underneath type 2. The M, it just, you see that the onset is during youth, or in other words, when you are an adolescent. Let's talk about GDM. GDM is basically being diabetic, but being diagnosed when you're pregnant. The vast majority of the cases, if not all of them, have existed before being diagnosed. Now, a woman, obviously a woman, gets pregnant. You know what? At least at the year 2018, it's still obvious. God knows where science is going. But never mind. Carry on. You most likely have diabetes type 2. You start getting more frequently checked because you're pregnant now, and you are diagnosed with diabetes. An important part to point to notice is that it usually progresses and becomes worse because of the pregnancy. Now, pregnancy within itself flips the body. The woman's body is transformed, especially at an endocrine level, and this is unfortunately fertile, no pun intended, grounds for mayhem. Then we have DKA. Very simple idea. Look, you have diabetes. You are short on the supply of glucose, which is crucial to the functioning of the nervous system and especially red blood cells. Now you have to produce glucose. The fastest way, besides glycogen, is actually to take apart proteins. But when you catabolize proteins, what we call proteolysis, especially the catabolism of the amino acid alanine, which has pyruvate in it, produces a lot of negative accompanying substances, such as ammonia, ketones, and so on and so forth. So the idea that glucose is being elevated in the blood is an indication that the body is going to have to find other ways to produce glucose, and that leads to ketones that can become toxic. Then we can talk about Hanks. We see that Hanks is usually secondary. You can see that we're talking about a glucose level of more than 600. So just to remind you, at above 250, we check ketones and we think twice if the person should exercise or not. With 600, the person is not exercising, right? Of course, it's going to affect already the pH of the plasma of the serum, and that is very, very dangerous. Of course, it makes blood more viscous. That immediately lowers stroke volume, elevates heart rate, and lowers O2 supply, which is, of course, a very bad idea. Then we can talk about SE. Um, in the heart of the idea is a unique combination where hypoglycemia is met with a trial to compensate. This trial goes wrong, and instead of getting it just right, it becomes over compensation, and you go suddenly from hypoglycemia to hyperglycemia. The rest few slides are pretty simple to get. When we talk about the dawn phenomena, we're talking about an early morning rise in glucose, although you had no hypoglycemia during the night. So it, it's elevated, but it doesn't seem to be a compensation for anything. So it's an abnormal reaction, um, mostly because of an imbalance in GH during the night. And then you can see chronic complications to DM. The idea is very simple. From having acute complications, you have a chronic imbalance that keeps reoccurring. Partially is because of diverting, or what we call shunting, glucose through parallel metabolic pathways. Um, in this case, the polyol metabolic pathway that causes glucose to accumulate and causes problems. The last complication that is very important, and we see it a lot in DM, especially chronic, meaning with time and age, and even more in women, is the microvascular disease, meaning that you are influencing capillaries. Uh, of course, when you talk about capillaries, anatomically, that moves you more towards the cell itself. And of course, we're talking about a direct influence on oxygen supply and delivery, meaning hypoxia and ischemia. Um, that's about it. So that is the only video for the endocrine system. If you have any questions, let me know.